Right. Good evening, good afternoon, good morning, wherever you are tuning in from. Welcome to Facebook Neurology for Vets live webinar. We are very pleased to give you an exciting webinar today from Dr. Sam Taylor. She's going to talk about some treatment research in FIP. So very exciting stuff. I'm going to give you a little overview of Dr. Taylor, for anyone that doesn't know her. Samantha graduated from Royal Vet College and completed internships in private referral practice before starting a Feline Advisory Bureau residency at Bristol University in the UK. She was awarded the European Diploma in Veterinary Internal Medicine in 2009. In 2011, she became an RCVS recognized specialist in feline medicine, and in 2019 was made a fellow of the Royal College of Veterinary Surgeons for outstanding contributions to the profession. Sam is an International Society of Feline Medicine Academy of Feline Practitioners lead and consultant, and also works in the clinical referral practice at Lumbury Park Veterinary Specialists in Hampshire. She is a visiting lecturer in internal medicine at Surrey University Veterinary School. She's on the editorial board for the Journal of Feline Medicine and Surgery and coordinates the International Society for Feline Medicine International Guidelines. She has written books, book chapters, and papers on internal medicine topics and enjoys a mix of clinical work, writing, and lecturing, and is excited to be involved in this researching the legal treatments for FIP, which is why she is here today. And we are very honored to have her here and for her to spare her time. You're extremely busy, we know, Dr. Taylor, so thanks for that. We're looking forward to this, what promises to be a great talk. Thank you.
Oh, no problem. If my dogs bark, I apologise. I just threw some of them out and they broke the door down to come back in. So
we like that. Proof it's live.
Well, yes, there is that. There is that. If you see me chucking a pug out the door, then that's why. Thank you very much for having me this evening.
Well, welcome here, and we'll get your show going here.
Right. Now, can I just check you can hear me okay, and you can see my PowerPoint all right?
You're ready to go good.
Good. Well, I'll get started then, if that's all right, because I'm sure everyone wants to get to MasterChef and matches and glasses of wine and things. What I wanted to do, and I really appreciate the opportunity to speak to you this evening, I wanted to tell you a little bit about our experience with the novel drugs to treat FIP from the UK. We also have some experience from other countries around the world as well to talk about. And I've got some photos here of some cats that we've treated that I'm going to tell you about during the talk. So I've just got a little disclaimer, forgive me. This is a hot topic, and I'm sure that we will talk about this, that there are illegal drugs that people can purchase, and the legal drugs are supplied in not every country, I'm sad to say, and I'm sure there are people listening who will be cursing us when they hear this talk because they can't get hold of these drugs. So, I just really want to let you know that we're not sponsored by Bova, who supply the drugs. We have no, other commitment or anything like that to them. So it's just to be clear on that. But we'll talk about this probably in some of the questions, if you have some questions about that. So what I'm going to do is I'm going to tell you a little bit of a case, about a case that we treated. And thank you very much, my neurology colleagues at Lumbury Park, for telling me more about this case. We'll talk about neuro FIP, which is slightly scary with a couple of legendary neurologists listening, so you can correct me when I get anything wrong. And then obviously we're going to go through the novel therapies for FIP and our experience, and I'll be asking for your help with our study. So let's get on with it, really. I want to tell you about this cute little cat called Fibonacci. And this is going to be a scenario that's quite familiar to a lot of you, but I hope I'm going to show you a little bit of a different outcome. So Fibonacci is a 5-month-old, cute, they're always cute, aren't they? Siamese crossed with a ragdoll, really nice combination. Male entire, lives with a sibling, nothing too exciting here, indoors. Been with the owner for, a couple of months now, fed a standard diet, good body size, so nothing too exciting there. And what Fibonacci presented originally to the referring vets for was a relatively acute onset of falling over to the left-hand side. And this was very alarming to the owner, and the cat was taken straight to the vets. The vet noted some nystagmus, and the cat was the rest of that day quite quiet and off food. And this prompted a referral, because obviously that was quite a concerning presentation. Now I am, gosh, scarily presenting a neuro exam, and again we'll talk about neurolocalization as well, which does make me nervous with this audience. So forgive the feline medic. On examination, we've got mild ataxia of all four limbs, a mild head tilt, and some nystagmus, and you can read on the screen here. So spontaneous nystagmus and rotary positional nystagmus with the fast phase to the right. So we looked at what the neurolocalization was and felt that it was probably, and again, interrupt me and correct me if I'm wrong, Laurent and Simon, but we felt that left peripheral vestibular was probably the most likely. The cat was quite quiet and a bit miserable, but we didn't have any other particular markers of central involvement. And we thought about some differentials like infectious, inflammatory. It's a very young cat for neoplastic disease, and quite a unilateral presentation for a metabolic disease like a shunt. So we took some bloods, and I don't expect you to read all of these. It's the evening, or it might be the morning for some people, but you might not be too awake. So I'm going to show you what the significant abnormalities really, and they perhaps follow a little bit of a predictable path given the topic we're discussing. So the globulins are elevated. I think you can see my cursor there. So we've got globulins at 57. We're going to ignore some other mild changes here. We've got a very mild anemia, a mild eosinopenia we're not going to worry about too much. We did do some toxo titers, which were not very exciting. So I'll let you think about that for a little bit of a moment. We did a couple more tests. We were very fortunate to be able to measure things like ammonia. We measured preprandial bile acids, not postprandial, because the cat was inappetent, so we couldn't get our postprandial levels. And because he presented to neurology, we did an MRI scan, and actually, Laurent, you're not allowed to critique the report here because I copied it and it was your report. So I copied it directly from your reporting. And on the MRI scan, the cat had some meningeal enhancement, especially around the brainstem. And you can read these other changes here, but that was the bit that I suppose my amateur neurology got me interested, was this meningeal enhancement, which we know can be a marker of an inflammatory central nervous system disease. We did a CSF, which again, I don't expect you to read all the text. You can just rush to the interpretation, although we tell you not to do that and read all the text. But this time you can just read the interpretation. We've got a marked neutrophilic inflammation, and we've got high total protein in the CSF. So I think you can see we've got some quite significant changes here that are very worrying. What about doing some further tests for viral antigen, considering what we're talking about? Well, we did run a coronavirus PCR on the CSF, which was negative, so not detected. So I suppose my question for you, given what we're talking about, can he still have FIP? And this is something we could spend quite a lot of time talking about, but I know you want to hear more about the treatments, but I just want to really put it in context. And also, given my audience this evening, who I don't normally speak to, talk a little bit about neurological FIP, because I think it's one of the most challenging forms of FIP to diagnose. You could argue that our other forms that we tend to see through medicine are easier to get a confirmatory diagnosis of. But we know that FIP is a common cause of neurological signs in young cats. And just a few points that I wanted to kind of make about neuro FIP. When you start doing post-mortems of cats with FIP, I always say to people, what you see clinically and what you see on imaging is often the tip of the iceberg. And so neurological involvement is certainly reported in cats that have presented without neurological signs. So we know that we can have central involvement without clear neurological presentation. And I think that potentially has an implication for treatment, which we'll talk about later. And remember, we can get neurosigns in combination with what we call wet or dry FIP. And we don't really like this definition. There isn't wet FIP and dry FIP. They're all part of a spectrum. And probably if we follow dry FIPs, they may develop an effusion. And if we do a post-mortem on a wet FIP, they will have granulomas in various organs. So don't think of it as two separate diseases. Think of it as a continuum of the same disease with variable presenting signs at the point that you're seeing the cat. So interestingly, with an abdominal effusion, you could still have neurological involvement, and with cats without any effusive disease, you could get neurological involvement. What you tend to see, and again, correct me if I'm wrong, but what I've certainly seen is it can be quite subtle signs actually in some cases. You could argue that this cat's signs are relatively subtle. We can see ataxia is a common cause of seizures in young cats, vestibular signs like Fibonacci's case, cranial nerve deficits, behavioral changes, often depression itself. We don't know if that's because the cat is feeling very poorly and is febrile, or could they have any central involvement. And running PCRs on CSF, as we did in this case, is certainly something that we would recommend, but I wanted to include this case because I think it was an interesting result. We generally recommend what we call sort of the quantitative PCR, so the PCRs that are going to give you not just a yes or no, but going to tell you how much virus is present in the sample. And the problem with PCRs is they can be quite specific if they're negative, but they can lack sensitivity. And if you look at some of the research on neurological FIP and CSF PCRs, we know that if you take a big group of cats with different types of FIP, we'll only get a positive PCR on the CSF in about 30% of them. If we take cats with neurological signs, that jumps up to about 80% of them. So it's not every cat, and that's why in this case my answer to my own question is yes, he could still have FIP. But if we get a positive result, then obviously that's highly supportive of the diagnosis with consistent clinical signs. And I include a post-mortem here from a cat with FIP showing some of the classic changes that obviously you guys will be more familiar with seeing on MRI. We tend to see this dilation of the ventricles and this meningeal enhancement. So here's an MRI from actually that case, and you can see the dilated ventricles there. The other thing that we sometimes see in neuro cases is concurrent involvement of the eyes. There's not much of a jump to see the connection between the two, and I think often if you did post-mortem a lot of cats with ocular FIP, they may have some central involvement as well. And here's an unfortunate cat with quite severe changes, severe uveitis and FIP. Now, a slightly controversial slide here, and I wonder if Laurent Simon will interrupt me on this one, but what I thought I might say is what us feline medics want the neurologists to know, because I'm speaking to a big group of neurologists here. And the first one might upset you a little bit, and that's that you don't always have to do an MRI. And I know that you guys do like to keep the MRI really, really busy. What has happened since we had available treatments is a slight shift and a slight change. We need to be confident of our diagnosis. Don't get me wrong, we do need to be confident of our diagnosis. But we need to think a little bit more, and we're going to talk about cost of some of these treatments. We need to think about our diagnostics with reserving finances for treatment. And unfortunately, MRIs and CSFs can be a very easy way to burn through some insurance funds. So what I'm going to ask you neurologists to do is to look in other places. So we will have cases that come through medicine sometimes, and all of us feline medics will talk about these cases that are presented with predominantly neurological signs. But when we do an abdominal ultrasound, we find free fluid, or we find a big lymph node that we can sample. And that's going to be easier. It might require sedation rather than GA. We need now to think about your sort of costs and what we do in diagnosis a little bit more, perhaps, than we did previously. So the discussion has changed, the diagnostic discussion, and then obviously the treatment discussion. Trial treatment is something that us as medics often don't like because it feels a little bit too much like guesswork. But the reality of the cost of some of these drugs means that in some neurological cases, when clients may be able to fund the treatment but not an MRI scan or a CSF, that you guys may have to trial treatment and look at response. And certainly that's, I have colleagues that have done this, and we've had cases like this where we haven't had 100% confirmatory diagnosis where we've started treatment and we've assumed from response that we are dealing with a case of FIP. Now, obviously there are some conditions that get better with time anyway, but clearly a consistent response is going to give us some evidence and some confidence that's what we're dealing with. So let's move on to why you're here after I've upset the neurologists already. I want to talk about treating cats with FIP, and we will bring this back to the case that I've shown you as well. So there were a lot of developments over the last few years in the treatment of FIP, and actually for some time we have known that there are drugs that are effective in cats with FIP. We have those publications, we just couldn't get the drugs. So we had, first of all, protease inhibitors, and then we started off with these nucleoside analogues, and a lot of this original work was done in the States. And these particular drugs, these nucleoside analogues, they basically upset replication of the virus, to put it simply. So these are what we really love and what we're using now. And they're obviously used in human medicine, or they've been trialed in human medicine, some of these drugs, because there are other nucleoside analogues that we can't get hold of at the moment that probably are also effective. So what happened? What was a really, really exciting development? I'm sure that most people watching have sadly had to euthanize cats with FIP, and we were just talking about this before I started speaking. We all can think of those cases, and so these developments were hugely exciting for us as vets to get hold of these drugs. But the Australians beat us to it, and so some of these drugs were available in Australia. Well, all of these legal drugs were available in Australia before they were in the UK, but the Australians have been very generous in sharing their information and advice with us, which we're very grateful for. So what we had first was remdesivir, and you can see a vial of it here, this liquid gold, I call it. It's a nucleoside analog that's metabolized to this horrible long number here, which I thought I'd never remember, and now is ingrained in my mind. So GS441524. And Australia had this at the beginning of sort of 2021. We got it in August. And this drug, if you're not familiar with these drugs, I'm just going to go through some of the background and the basics of it. If you're using them, brilliant, and we can talk about your experience. So remdesivir is given IV or subcut more commonly, but it can be given IV. And then we had another brilliant development in November in the UK, where tablets and an oral treatment of GS441524 was available. And this was brilliant, because I'm sure you'll agree that injecting cats daily for 84 days is quite an alarming thing to do. And yes, I'm going to tell you about the duration that you need to treat these cats for. So we have essentially the same drug, but in two forms in the UK. Now in Australia, these are also available, and they can be exported from the UK and Australia to other countries, depending on the import rules of those countries. So I know it's so fortunate to have lots of people from other countries here. So remdesivir, here it is. This is me using it. I get so excited, I take lots of photographs of it. It's sad. I've got so many photographs of vials of this stuff, because it's the stuff of our dreams, really. It's 10 mg per ml. It comes in 10 ml vials, and you give it, as I've mentioned, subcutaneously or IV. If you're giving it IV, you need to dilute it, and you need to give it quite slowly. And interestingly, after you give it IV, the cats may be a bit lethargic and not so well. And humans who've had remdesivir apparently report similar thing of feeling kind of worse, feeling a bit lethargic and a bit unwell for a short period after they've been given the drugs. So in general, we're using the IV treatment in quite sick patients to try and get that serum level up very quickly. And that has been the neuro patients, actually, as well as the non-neuro sick patients. But your severely affected neuro cats, I certainly would be considering giving this IV. If you've got a seizuring patient or an obtunded patient, or anything like that, it's brilliant, because you can start to get high levels very rapidly. Then, and there will be a few questions about this, about how long we do it for, and some of them I can't quite answer for you yet, but in general, we're going to follow it up with subcutaneous treatment, probably for a couple of weeks. That was our advice before. Certainly some centres have shortened this, and I have had cases where I've shortened this and not seen that it's to the cat's detriment. So we don't know exactly how long we should continue it subcutaneously. Generally IV, we're just going to be using it for 3 or 4 days, and I can tell you they look a lot better after that, and you can change to subcutaneous, but some people are now changing to oral a little bit sooner, obviously for various reasons, and cost can be one of them, because the oral drugs are cheaper. So let me tell you about what we've got orally. 50 milligram tablets. They come in these little pots with only 10 tablets in it. It's a big pot, but only has 10 tablets in it. You can divide it and you can crush it. So if you need to crush it, and we'll talk about how we get it into the cats later, you can divide it and you can crush it. So lots of cats are little tiny cats. They only need half a tablet. Ideally, we don't go to a quarter. We'd probably dose upwards, but you could. It wouldn't be a problem. Ideally, the GS is given on an empty stomach, and that can be quite difficult for some owners. So if it's in a little treat, or I'll show you later some ways to give it with Licky Licks, that's fine. But what we tend to do is advise that its food is lifted up at night and it's given first thing in the morning, for example. If you are treating neuro cases, you're going to be using higher doses, and in that case we do recommend you divide it into 2 doses. So if you're giving over 15 mg per kg, I'll show you the doses in a moment, but you will be doing that for ocular and neuro cases and some of the other cases, then divide it into 2 doses. And there's a little bit of data that we're waiting for from Australia suggesting a shorter half-life, and that with the oral treatment, and perhaps we should give all cats twice a day. So if I have a cat that's not responding as well, that might be something that I would think of doing, increasing the dose and dividing it twice a day. So what about dose and practicalities? And this is something that we get asked a lot about. So myself and several of my colleagues and feline medics, we run an advice service that we just run for free. It's not, it doesn't involve BOVA in any way, who supply the drugs, but just so that we could help people with some of this information. And most of the questions that we get are about dose and about relapse, which I'll talk about as well. And it really depends on the type of FIP. Basically. So we know that the neuronocular cases need higher doses, and there's some evidence published already that perhaps those are the cases that are going to relapse if we don't hit them a little bit harder with that dose. If you don't have any ocular or neuro signs, you can use a lower dose, but what we've really learned over time, and I've certainly learned, is that, you know, we don't hesitate to increase the dose, and if we try and save money by using lower doses, we actually probably that's to the cat's detriment, and using higher doses from earlier on, or if we have any doubt about response, is probably better. And I wonder if some of those cats that don't have clear neuroscience but don't respond quite as well as we would like them to, perhaps if they had a post-mortem, you know, they would have more extensive involvement. And that's the problem with doing less diagnostics, because then you don't quite know where the FIP is. But my message would be, don't hesitate to increase the dose. And the other thing is to weigh them very regularly. So if we don't keep an eye on their weight, what we have seen happen is these cats feel loads better and they gain weight, and their milligram per kilogram dose drops quite dramatically by the end of their treatment, and then we risk them relapsing. So you will talk about monitoring. You need to see them to weigh them, or the owners need to weigh them at home. So here's some examples of doses, and I don't expect you to write all this down. It is in the article that we wrote most recently for the Vet Times, and you can get this information also from ISFM. So for neuro cases, you can see we're going to be using higher doses once a day if we're using remdesivir, and then we split that once we get to the higher doses using the GS. I would say that we've certainly seen effusive cases that are not responding to these type of doses and responded when we've used higher doses. So I suppose this is all changing as we learn. So the initial dose recommendations and what the Australians were using was 6 to 8 mg per kg, and now we feel that is too low. There'll be a proportion of cats that respond to that, but there's a proportion that don't, and they probably are more likely to relapse. And that's what's really difficult about this disease. So if in doubt, round up. And what I would urge people to do if they're not using this drug at the moment, or if they're using it already, is to think about the markup. These are really expensive drugs, and if we put 100% markup on them, it will not be possible for you to treat these cats, and then no one wins. No one makes any money, and the cats are not with us anymore. And so most centres have agreed to put 20 to 25% markup, a bit like you would on another very expensive chemo drug, for example, something like that. It's got to be considered in a little bit of a different way. And so, yeah, my recommendation is really to sort of think about maybe using higher doses. I've had some people sort of ask or say, oh, why have you increased the dose when they had dry FIP and I was using the dry FIP dose? And I suppose my message on that would be that it's really individual. That's what we're finding out. And that probably is, as I mentioned, because we don't quite know the extent of the disease. So look at the cat, not the dose. Look at the response, particularly clinically, rather than sort of worrying about fixing to a certain dose. And if in doubt, go up. So yeah, it's a long treatment, and there'll be people out there sort of flinching. 12 weeks of treatment. Now, 12 weeks of treatment, subcutaneous injections obviously was quite a big ask. But remember, oral medication is also a challenge in cats, and I wouldn't fancy giving 84 days to my cat. And so another big message is to help your clients with compliance with these drugs. They're really expensive, each tablet. You do not want that spat out and to find it behind the sofa later. We need to help our clients with giving this drug, and I'll show you a bit about that later. The reason we need to give it so long is because the virus is, damn persistent, and so it's still in the macrophages. If we don't continue for that length of time, then we risk relapse. Now, there are cats who have been treated for shorter durations and seem to be cured. Again, this is so variable, and we'll talk about cost limitations. We don't want to compromise on dose, but in some cases you will have to compromise on duration of treatment, and cross your fingers that those are the cats that would respond to a shorter duration. Ideally, we only stop at the end of this 12 weeks if we've had clinically normal examinations and the cat is normal to the client and the bloods have been normal for at least 2, but preferably 4 weeks. And so you can schedule your checkups kind of according to that. So what do we expect with our treatment? Well, the temperature usually resolves within days. We find that and appetite and things respond very, very quickly. The effusions can take a little bit longer, but if they're taking longer than that, I would worry that you need to increase the dose. Your things like hyperglobulinemia should normalize certainly by 6 weeks, if not sooner. You can get an increase in globulins initially because you've got tons of globulin in all this effusion and it's all going to get reabsorbed. So you may suddenly, after sort of 1 or 2 weeks, if you repeat the bloods, be worried about that globulin sort of level. But look at the effusion, look at the clinical signs. And anemia seems to be a little bit slow to respond. And I'll show you one experience we had a few weeks ago. This is a beautiful little cat that I'm treating called Hudson. And when he came in, he was absolutely miserable. He didn't move from this chair for the whole consultation. He just sat there, and he's a little British Shorthair, and they're usually, real live wires, aren't they? And this was him after 1 dose of remdesivir subcut. He started attacking my lovely resident's feet. And as you can see, interactive, much, much improved. And that was after 24 hours, because this was when he was going to have his 2nd dose. So we can see some quite dramatic responses, not in every case. And I've found the neuro cases to be a little slower to respond. This cat has a classic mixture of sort of dry and wet FIP with a small abdominal effusion. Oh, I can't get rid of him now. So what do we monitor while we're treating? This is going to depend how, sort of financially, to be honest with you. Perfect world, we'll see them every couple of weeks. We will sort of be monitoring their weight, doing clinical exams. That may not be possible. Clinical response is, brilliant to monitor. How are these cats doing? I usually say, can we see them after a week to recheck their temperature, for example, and just see that everything's going in the right direction. And then I'll tend to do bloods after 2 or 3 weeks to just see that that's all improved. So, for example, with Hudson here, he had a hyperbilirubinemia, he had a hyperglobulinemia, and after 2 weeks that was resolved. We do think that 6 weeks might be quite an important point where we want to see the bloods normalizing. Of course, some of your neuro cases will have completely normal bloods, and in that case, save the money. Don't bother rechecking their bloods if you think that you're happy monitoring your neurological exams, for example. But in the other cases, I think 6 weeks is a point where we've still got an opportunity to increase dose if we're not quite there yet. And so that can be an important point. And then again, just when you're thinking about stopping, to make sure that we are clear, we're good to go. And just one of my bugbears is coronavirus antibodies. We get asked questions sometimes of people trying to monitor treatment with coronavirus antibodies. But, we know that coronavirus antibodies are not really useful in the diagnosis of FIP, and they bear no relation to response to treatment. So they probably will remain elevated or not, whatever they fancy. They don't reflect response. And I certainly never measure them anyway. I'd rather save that money for treatment now. Controversial. What adverse effects might we see? The honest answer is we're still learning. I'm going to tell you about the study that we're doing. And one of the reasons we're doing this study is to look at some of these adverse effects. I think that we are consistently seeing some elevations in ALT. We had one case where it was very, very high that resolved when we stopped the treatment. Most cases, it's about 1 to 200, not higher than that particularly, and it grumbles along, and we monitor it, and then when treatment is stopped, it resolves. So I don't panic, basically, unless it is, getting higher and higher. I think that's something that we are seeing. Some people report an eosinophilia, and actually the Australians felt that was quite a positive sign if they saw an eosinophilia. I can't say it's something we've seen in our cases that we've treated. Be interesting if anyone else has. And we've had a couple of reports of lymphocytosis, but I'm still analysing our data, so I don't know. I can't tell you a lot more about how frequent that is yet. And I mentioned to you about feeling a bit rough after the IV injection. Another important point is that pleural effusions seem to worsen initially, and then you may have to drain them again. So you may drain them once, start treatment, and after 24, 48 hours, have to drain them again. But please don't give up, because that seems to be an initial worsening that then will resolve. And I mentioned to you about sort of worsening hypoglobulinemia. And what we've seen in some cases through our advice line and through the cases that I've treated is some little hiccups sometimes. So Hudson, for example, after 2 weeks and responding really, really well, then had just a few days of being really, really lethargic. He had really horrible diarrhea, and we don't really know what that was all about. It was a bit of an odd hiccup. We did increase the dose, but whether he would have improved anyway. Injecting remdesivir is painful. We've had some success with using gabapentin, so giving the cats gabapentin a couple of hours before the injection is due. And if clients are injecting, we've got to help them. So we need to teach them like we would a diabetic. Change needles, make sure they're really sharp, try and make it positive with reward and training. But some clients are going to the clinic every day for a nurse to give the drug because they don't want to give it at home. And that will obviously depend on the client, the cost, and how the cat tolerates that, really. So what if they don't respond, or what if they relapse? And again, we're really learning about this at the moment, and we get lots of information from our very helpful Australian colleagues. The first thing I always say is just go back. Have we missed something? We know that FIP can look like other things. And if we are going to take our foot off the gas slightly on diagnosis, if we have to save some funds, I know we don't want to do that, but that's real life, then think about whether you've missed another diagnosis. Was it actually a lymphoma? Was it actually a TB? Was it actually a toxo? Hence it's not responding. If we are convinced, then up on the dose, increase it, and then correspondingly extend the course so that we've got that really clear bit at the end where the cat's responding well. And some question marks. Do we add in another drug? That would probably help, but we're limited on our options. We talk about a drug called mefloquine, and I'm happy to answer any questions about that. It's actually an anti-malarial drug. Slightly controversial, and some people think it's not effective. The Australians have thought that it was helpful in some cases. They've added it in at the end when cats are not quite responding as we would like, and they've felt that in some cases they describe it as sort of holding it. Whether it's having a huge effect on the coronavirus, we don't know. What would be best in treating viral disease would be to use 2 drugs, and there are some drug options that would be really good, but we can't get them at the moment. So I think watch this space in the future. It might be the cats that don't respond brilliantly, we add in another drug. If they relapse at the end of the course or afterwards, then what I said about how long this virus can last in the macrophages, you're going to have to go again. Now that's going to be cost prohibitive for some people, and that's why it's worth pushing it earlier, if you see what I mean, and making sure you've got a good enough response. But you need to warn your clients that this, much as we're super excited about it, and I have to temper my enthusiasm and say that not every cat responds. I almost think of it a little bit like treating lymphoma, although it is more promising than that. But you've got individual response is variable. You may need to decrease doses, and that relapse is possible. You could, in that situation, avoid, sort of miss the remdesivir section of the treatment and go back in with a higher oral dose. And hopefully we can answer some of these questions, but I do think that owner communication is really, really important. And I'm honest with our clients and say we're learning. There's not much published. We're doing our best, and we record that we've discussed that relapse might be possible. Now, I know you're going to ask me, what if they don't have enough money? Because the reality in the UK, and forgive me, I don't know exactly the costs in Australia and exports from Australia, but in the UK, you are talking about several thousand. It depends on the dose that you use. But you're probably talking about a minimum of 3,000, something like that. And if you're using the high doses for neuro-FIP, depending on your markup, depending on the number of checks that you do, you're going to push to 7,000, 8,000. I know these are eye-watering and I hate saying it. So if your client has limited funds, you see why I'm talking about not doing the MRIs. If the client's got limited funds, be realistic with them. They may feel terribly guilty that they can't afford something that's available. Let's look at what they can afford. Don't reduce the dose. I don't think that's the way to go, but use the recommended dose and think about how long they can treat for, and warn them and cross everything that they'll be cured with a shorter course. Whether there's an argument for putting those cats, when they run out of money, to be honest, on mefloquine, because that is a drug that's quite cheap. It's vastly cheaper than GS. We don't know if that's helpful, but it makes us certainly feel better and that we're doing something. What I would say is don't go mad on your rechecks if they're short of funds. Clinical response is really important. Maybe do some bloods at 6 weeks. That point that I said was important. But I like to clip in the cats with a big abdomen, clip a bit of hair on their back and get the owners to just use that as a mark and use a tape measure and measure. That's free. They can weigh the cats at home, or they can come in through a nursing clinic. Not that they should be free, but they can come in and be weighed, and you can minimize the cost of all these rechecks. But yeah, the owners have got to understand this, and we have had a situation where clients sort of thought they got all the money back if the cat didn't respond. Not the vet's fault at all. I don't know where they got that idea from, but cover yourself. Make sure you've had those conversations and write that in the notes that they understand. So let's go back to this cute guy. Let's go back to Fibonacci. What did we do? Well, we started him on remdesivir. And actually, at that time that he was treated, we started him on a dose that I now think is too low, and now we would use a higher dose. But at that time, we were sort of still learning about the doses. And so he was started on that dose. And we taught the owners how to do the injections, but it's really difficult on wriggly kittens, and the owners are paying for a lot of this themselves. I wouldn't fancy injecting a wriggly British short hair for weeks on end. Predictably, he didn't really like the injection, so he actually ended up kind of staying with us for a few days. And that's what we have done, is sort of keep them in for a few days to get them started. That will often help their appetite, and then owners will be able to medicate them better orally. So with him, we gave him some gabapentin to help with the injections, and that does seem to help. He had his weight checked. We discharged him, and actually his neurological signs pretty much resolved. They'd improved quite significantly after about 48 hours and then had resolved after about 5 days. But remember, he's going to grow, so we're going to check the dose. So here's the outcome. The owners, I quite understand, struggled a bit with the injections, but they did it. After a couple of weeks, he was changed to the oral drugs became available. He was here at a time when it was all sort of changing and the drugs were becoming available. And he'd actually gained weight from that time, and we upped him then to the higher dose, which again fitted quite nicely. So often they fit quite nicely, these little cats, to if they're 2.5 kilos, to the sort of tablet size of once or twice a day. And the owners were very relieved to use an oral drug, and he completed his therapy, I think about 3 months ago now, and hasn't had a recurrence so far. So let's give you a couple of tips. This stuff is magic. So here's Hudson again. Now Hudson absolutely loves this stuff. Let me just you don't want my voice in it. Take my voice down. So here's Hudson eating some Licky Licks. So if you're not familiar with Licky Licks, it's a very useful treat that you should have in your consult room. And he loves it, and he can be medicated by crushing the GS in the Licky Licks. And here, look at this. Now this lady, this is Leo, and now watch Leo. Let me just take my volume down. Watch Leo. He likes the Licky Licks very, very much. That's a tablet of GS, and he likes the Licky Licks that much. And the GS seems to be quite tasteless. He looked like he'd made a bit of mistake there eating that, but he's pretty happy now. So my other message is help your clients with compliance. So Hudson here on the right, when I told the client she was going to have to do 84 days of therapy, she cried because at that point he was inappetent, and she said, how the hell am I going to give him medications? And that's why I'll sometimes hospitalize them until they're eating a little bit better. But help your client. Licky Licks is your friend here. So FYP, where are we in 2022? Let's show you a few photos. So here's Hudson feeling lots and lots better. He's 6 weeks into treatment now. His bloods are normal. This is a beautiful Maine Coon. Now this Maine Coon weighs about 8 kilos. So you can probably do the maths on the cost of his treatment. So Maine Coons, stop getting FYP. It's really expensive because you're very big. This is beautiful Millie, whose owner came in a taxi every day. At that point, we only had remdesivir, so she went in a taxi to her vets every day for 84 days to have the treatment, and you can see she's pretty happy. And this is a cat called Leo, who again has had a full treatment and had some hiccups on the way and some persistently high globulins, and we've learned a lot from Leo. So thank you very much to the vets who've let me use these cases and use their cats' photos. So before you all fall asleep, I just want to ask your help. If you have used the product remdesivir or GS441524 from Bova, it has to be from Bova. We can't use the drugs that have come from other sources because we just don't know how much GS is in them. But myself and Seb Tasker, Emmy Barker, Danielle and Steph, we're collecting the cases. So if you've treated one, please drop me an email and let me know, because we would love to steal your data so that we can learn a bit more. This email address is also available to you if you need advice on a case, and we're very happy. We'll often send you all of our articles if you want to keep them, and otherwise we'll just try and help the best we can. So I want to thank you very much for listening and hand back to Laurent and Simon to see if they tell me off for any of the neuro content that I had in my talk.
100% no, Sam. Thank you very much, and again, brilliant, presentation. As you say, there is still a lot of unknown, and is reflected in some of the questions we had, about is it going to be, a cure, and when they're likely to relapse and so on. But the aim of this presentation was to make people aware, that you and your team have made, remarkable progress for something that, for years we consider as a fatal disease, and it was a death sentence for our patient, and having now a treatment option is actually, really groundbreaking. I just have one question before I put a few questions from the audience. It may sound a silly one. As neurologists, when we had neurology FIP cases, they tend to respond maybe non-specifically and for a short period of time to corticosteroid. And that from the human coronavirus for critically ill patient, dexamethasone is part of the treatment, and it has definitely shown to improve. Have you looked at combining or using dexamethasone or steroid in addition to to your antiviral?
We haven't looked at it specifically. We're hoping that the data we're collecting might answer that question. A lot of them are on steroids anyway, because of a non-specific treatment or waiting for a diagnosis, for example. And as you say, a lot of those young neuro patients will respond for a short time to steroids. There's actually a bit of a feeling that we shouldn't use steroids in combination with these drugs, probably because of the immunosuppressive type effect, and we're trying to target an antiviral with an antiviral. So in general, we advise that you wean off the steroids whilst you're starting the antivirals. That may reflect our confidence in a response. But I have to say that the really severely affected neuro cases, we haven't quite been brave enough. We have started steroids as well, but once they've started to respond, we've then weaned them off quite quickly and then seen a sustained response. Not in every case. So the response rate we're seeing in general, and I'm generalizing and we haven't got all our results, is about 80%. So we're seeing the majority of cats respond very well, and the majority of those cats go on to be cured. And so we think that we can look at around 70 to 80% of these cats being cured of FIP. That still means that there's a proportion that won't respond. And we've heard of a few particularly severely affected neuro cases that have not responded or have responded briefly and then seem to relapse. Whether the diagnosis was obviously sometimes we're limited with diagnostics in those cases, or whether they have such changes. I'd like your thoughts actually, whether they have such structural changes perhaps in their brain, or even if they have scarring preventing CSF flow, would they have ongoing neurosigns? I don't know what your thoughts are.
It may be the same, the same issue that we had with bacterial meningoencephalitis or bacterial meningitis, even if the pathophysiology may be different. Initially a short course of corticosteroid has shown to be beneficial for 48 hours, but then longer, as you say, may affect the immune system and maybe detrimental. So maybe in this case, it'd be worth a short, a 48 hours, and then, moving on to the solely with antiviral. We're just going to take a few questions. I'm mindful of the time. There was a question about, when after 44 days treatment, what we have to check to be sure that L5P will not come back, or when do we know if we treated enough,
Yeah, I mean, we are considering that 84 days kind of the minimum treatment period if it can be afforded. And after that, the simple answer is we don't know how often we should check them, and it often depends how much finances people have left. So what we're generally saying is that monitor clinical response. That's going to be your most reliable thing, is how is the cat, and body weight. So I tend to say have them in a couple of weeks after you've stopped. You don't need to wean it off, just stop. Have them in a couple of weeks later and examine them, take their temperature and weigh them. And then I might see them a month later and do some bloods. But if we start doing lots and lots of bloods at that point, we're going to spend a lot more money, when I think actually the clinical response is the most reliable. And they're probably at most risk of relapsing in that period, that month or so after you've stopped treatment. But again, we're learning about that. Is the true answer.
A similar question, when are we expecting the relapse after stopping treatment? I mean, I presume it's still unknown, but if you have
it is. I have to say that if most of them, if they've got to the 84 days and we've used a high enough dose and we have done monitoring during that treatment time and they've been sort of clear, we're not hearing about a lot of relapses. Hopefully the study will show this, but I think the Australians would agree that we're not hearing a lot of relapses after that time. What we are hearing more of through the advice line is relapses whilst they're on treatment, or failure of response, or an initial improvement and then deteriorating. I would say that's more common for us to hear. But the theory being that if we then increase the dose, we can still get a cure from there. We've seen some that have limped along a bit, not been 100%, and those are the ones we really worry about, because we've not had a clear period, and probably they need a second antiviral that we can't really give them at the moment.
Some very practical question. We take a couple more. Could you confirm that GS is crushable in food?
Yes, it's not coated sort of in any way. It's not one of these sort of, it hasn't got a particular coating on it. So Bova tell us that it should be fine being crushed. And actually my little British Shorthair, there's no way we can medicate him otherwise. And he seems to be responding very well. There are potential issues with GS and absorption. And possibly that's why it would be useful to use remdesivir initially. But I think if we try and use the minimum amount of food and try and sort of have an empty stomach and then not feed them for an hour or so, that's the general advice that we're giving. But certainly you can crush it in food. We haven't seen any negative effects on that.
One before last, is the 84 days including IV and sub-Q injection?
Yes, it is. And so before we had the oral treatment, we just gave 84 days of injections, which, was a tall order, but there were cats that were cured from that. So now what we would do is, if we did the week or 2 weeks of remdesivir, you'd take that off your total time, so that the total treatment is 84 days, but extend it if you have concerns about response.
And the IV is diluted in saline, isn't it? It was a question about. Last one, and then we'll have to call it a day. Do we have a toxic dose or safety margin known for either remdesivir or GS?
the simple answer is no. They're doing in Australia. There's a lovely lady called Sally Coggins who's doing an extensive project on the pharmacokinetics of these drugs, and we hope that'll answer a lot of questions. But I have to say, at the moment, we are seeing these odd adverse effects at lower doses and higher doses. We tend to not go much above 20 because the feeling might be that actually they're not going to. There's no benefit from increasing higher than that. They're not going to respond. So that tends to be where we get to when we start to worry about resistance. It's a virus, it can be resistant to treatment like anything else, and that's why we've got to use it quite responsibly. But I think there is resistance is possible, and so once you get to that dose, there's probably no point going higher and higher and higher.
Thank you very much, Sam. Sam, if you want to reiterate, your call for cases, again, that's the only way to answer so many of the questions that people have put.
Yeah, I mean, it's one of these things that it would be lovely to do a really controlled study, and have it all perfect. And, it isn't. This is going to be a clinical study. We would just want to know what's happening out there. Even if you don't have all of the checks, even if they've just been monitored clinically, there are cats out there that have very little monitoring because they've responded really well. We still want to know about them, or if they haven't responded well, we want to know about them. So it doesn't have to be a perfect referral workup. In any FIP study, you'll see they have presumptive diagnosis, and we know we're going to have that for some of them. That's going to be my job to tidy that up into a study. But I think we'll still learn about some of these, these questions that I can't quite answer. We'd love to be able to answer them. I don't think it'll answer everything, but it's the start, isn't it, of getting that information together. So if you've treated a case, we'd love to hear from you within GDPR and sort of data protection and things. So if you drop us an email, we'll let you know how to give us that data, within all legal confines.
Fantastic. We had at some point nearly 800 people listening to you, no pressure. And we have people from all over the world, going from South America to Taiwan, and it was widespread.
Well, I'm sure it's very frustrating for some of them if they can't legally get these drugs. That's my only sympathy to people listening from those countries. And what I can say is we're trying our best. By publishing, we hope that other countries will see the efficacy and then allow us to export it. That's our aim of this study, actually, is to have a document saying, this works, this is safe, your country should allow kind of import, and then we can all use it. That's what we want.
Simon, you got the last word, but Sam, if I can just say again, thank you so much, and I hope you get plenty of case to carry on this very useful research. Definitely.
Thank you. Thank you.
Yeah, thank you very much, Sam. That was fantastic, very, very thorough and clear, and hopefully helped a lot of people with some of these really burning questions. So anyone out there, if you do have cases, please get in touch with Sam, and hopefully this session has really spurred that research on. So thanks for giving up your time. We know it's late there. For everyone else tuning in, we'll be back on June the 8th with the Hallmark Journal Club series. We're going to be looking at a new paper out on MRI of lateralized discs by Dr. Sarah Silver. So we will see you then. Thanks again, Dr. Taylor.
You can stay online, Sam. See you. Bye-bye.